The congenital eyelid defects that are usually encountered by the reconstructive surgeons out there, and usually it's a team that is incorporating to treat these patients who are suffering from the congenital birth defects or the congenital eyelid defects. Usually it's a team that is compromising the pediatric surgeons, and then we have the ophthalmologists, and then we have the reconstructive surgeons who are working out or treating these patients who are suffering from the congenital eye diseases. First of all, giving you an overview regarding the eyelid anatomy. So again, it's very important to give you an overview that there are these some structures that are giving the construction of a complete eyelid in an individual. It's usually the levator palpebrae muscles, and then we have the palpebral part of the orbicularis muscle that is contributing towards a complete structure of the eyelid. Again, if there is any birth defect that is compromising or that is giving its way, it can be a ring defect such as a coloboma. It can be any other birth defect that is giving way to a normal reconstruction of the eyelid. It can be any abnormality with the glands again out there. For example, you can see out here that just to give you an overview, we have a lateral horn of the levator aponeurosis that is contributing towards, again, the normal eyelid anatomy. If there is any abnormality that is relating to this levator aponeurosis or even the muscle itself, again, it is going to manifest as a birth defect in the individual. Then we have the lacrimal gland itself. So if there is any birth defect that is related to the palpebral part or again the nasal part of the lacrimal gland, again, that is going to result in the corneal ulcerations. The tear formation is going to be affected in these individuals. And that is again going to manifest as some of the complications that we can relate to. Then we have the punctum over here that is related to the lacrimal secretions, and this punctum is eventually going to drain into the nasolacrimal duct that is lying over here. The ampulla that can be again defected in the individuals by birth. We have the canaliculi. We have basically two canaliculi. So if one of it is defected or if one of it is blocked, the other can function quite normally. So the blockage would be, or any complication would be resulting if there is a defect completely in the canaliculi. Then we have the lacrimal sac, and we have the abnormalities that can be related to the lacrimal sac itself. We have the ductules out there. So all of these anatomical structures and any defectual complications that are related to these anatomical structures can result in the complications in an infant. It can be a muscular defect. Either it can be a neurogenic defect or it can be any maternal drugs that can affect the infant as well, and that will manifest as a congenital problem in the infant out there. Even it can be any traumatic defects, even trauma that is related to the birth trauma will manifest as a neurogenic defect in the infant. So we can basically divide or we can classify the causative factors into the neurogenic, we have the myogenic types, we have the traumatic types, and on the other hand, we have the infectious types out there. Relating to the anatomical structures, it can be the trauma to any of these anatomical structures. Either it can be the infections to these any of these anatomical structures or any birth defects of these anatomical structures. So knowing these structures and knowing their functions is quite important out there whenever we are relating to the congenital eyelid defects. Then the lacrimal gland, of course, the nasolacrimal duct or the inferior, the middle meatuses, and then we have the superior meatuses. Why are these meatuses important out there? That is again one of the very important questions. These nasal meatuses have their related openings, have their related anatomical openings. It can be the openings to different sinuses. So if there is any abnormality that is again congenitally manifested in an individual, that is going to have its own complications. So we have these meatuses, and along with them, we have the turbinates. Turbinates are basically the osseous structures that are related to the meatuses. And obviously, they don't have the openings. The openings are usually incorporated into the superior, middle, and inferior meatuses or the inferior turbinates. The eyelid examination. So whenever we are going to carry out the eyelid examination, whether it is an infant or whether we have an adult patient out there, we have to focus on these facts that we do not need any special instruments for the eyelid examinations. We do not need the ophthalmoscopy. It's just the simple, even it can be a slit lamp examination, or even the torch illuminations are sometimes beneficial in this regard. First of all, we are going to examine the eyelids in a procedural manner. It will be a lower eyelid examination, and then it will be followed by the upper eyelid examination in a patient. So focusing on the lower eyelid eversion, we're going to see that we're going to slightly evert the lower eyelid, and that is enough for the lower eyelid, because the structures involved in the lower eyelid are not quite extensive, and just a slight eversion is sufficient to reveal any abnormalities that is related to the lower eyelid. It can be any infectious states, for example, styes or chalazions, or it can be any other structural abnormalities, for example, any ring defects or any other conditions, for example, the lash abnormalities, blepharophimosis, or the entropions or ectropions can be evaluated over here, or any signs of irritation are looked for. You have to look at the conjunctiva. You have to look at the sclera out here just to have a complete view whether there are any signs of irritation or any other foreign body sensations that are complained by the patient that are going to be assessed out here. And then we're going to focus on the upper eyelid eversions. So it can be, first of all, just a slight eversion is done just to see or just to have a complete look at the lashes. Is there any signs of trichiasis? Now, trichiasis is another phenomena in which we have extensive lashes, and that is again going to cause the irritation to the conjunctiva and to the sclera. So the signs of irritation or the signs of foreign body sensations, these are the complaints that are put forward by the patient. So they are going to be looked for whenever we are examining this patient of eyelid eversion or eyelid defects, or the patient has come up to you and he's complaining of any other foreign body sensation or irritation. First of all, a single eversion is needed just to have an overview, and then we have a double eversion of the upper eyelid. So the upper eyelid have extensive structures. We have the palpebral part of the lacrimal gland that is closely related to the upper eyelid. Again, we have all the other anatomical structures that are related to the upper eyelid. So there has to be a double eversion just to have a complete look whether there are any signs of inflammation, there are any signs of irritation, any other arterial proliferations that can be noted down, and all of this conjunctiva and the healthiness of this conjunctiva, sclera, all of these protective layers is noted down whenever we perform this single or double eversion in these patients. So this is a complete overview whenever we have to examine these patients in detail. Talking about the congenital eyelid defects, a very important condition is the coloboma. Coloboma are any ring defects that are encountered by the patient in any of the anatomical structures of the eye. It can be the eyelid itself, it can be the iris, it can be the lens, it can be the retina that is involved in these congenital ring defects that are observed in these patients. Over here in this diagrammatic review, you can see that we have a patient who has a coloboma in the iris over here. So it is basically an iris defects that is observed in these patients over here in this particular patient. But we can have these ring defects in the eyelid, and they will have their complications accordingly. The clinical picture would be accordingly, the complaints would be accordingly. If it is an iris that is involved, the vision is going to be involved effectively. If the retina is involved, again, we'll have a wide scotoma or a visual field defect that is observed by the patient. If the eyelid is involved, it would be like somewhere over here in this eyelid. It can be a 40 to, it is depending upon the percentage of the eyelid that is involved over here. If it is the percentage is big enough that it's almost involving 40 to 50% of the eyelid, then obviously it will have its complications at its worst, ranging from the corneal ulcerations, the infections, and the visual field defects, and all of these complications would be related to it. So it's basically, you can just correlate this condition, which is known as coloboma, with the ring defects. It can be any of the structures that are involved in the eye. This is the clinical presentation when you have this coloboma in the eyelid. So we are done with the iris, and now we're just looking at a picture in which we have the eyelid defect or the ring defect that is situated in the eyelid. Over here you can see that even if the palpebral fissure is closed, it won't be approximated enough, and there can be the complications of corneal ulceration in these patients. So that is the reason that these patients are suffering from the corneal ulcerations over here. Again, it's a minute coloboma, not involving almost even 2 to 3% of the eyelid, and it won't have that much of the complications, but still you can see that upon the closure of the eyelid, there is still a window that is exposing the eye towards the outer atmosphere, and that is again going to result in the infectious states, or either it is going to result into the corneal ulcerations or the keratitis in these patients. Again, you can see that there are slight chalazions, there are slight styes. Now, stye is basically an infectious condition which is upon the eyelid. Over here you can see that this stye is present on the lid margin, and that is, again, it can be secondary to this coloboma that is present over here. It's basically the ring defect that is present over here. Again, this patient has chalazion even, that is a far away eyelid infection, and all of these infections can be secondary to this coloboma condition out here. The treatment again would be surgical in these conditions. The medical treatment, that would be prescription of the eye drops, that would be just to correlate to the infectious states or to correlate to the keratitis or the corneal ulcerations. We can prescribe these patients to the tear films or the natural tear drops, just to have, just to avoid the dry eye syndrome in these individuals. But over here, you can just focus on this fact that the surgical treatment is usually regarded whenever we have a coloboma that is big enough, that is involving almost 40 to 50% of the eyelid margin. As you can see over here, we're just going to freshen up the margins whenever we're going to perform the surgery, and we're going to approximate the two ends. First of all, we're going to freshen up the margins in these individuals out there. And then further on, we're going to approximate the two ends. So it can be a two-layered surgery. If the defect is big enough, it can be a two-layered surgery in these individuals. So it is performed in a step-by-step manner, and it's usually the levator muscles are also involved along with the fascia and the skin out here, and then the two ends are approximated in these patients. So over here, you can see that these sutures are, again, it can be a Z-plasty. That is usually the terminology that is given out there to the two-layered structures that are basically performed in two folds whenever there is the coloboma that is involving almost 40 to 50% of the eyelid margin. Sometimes the lateral canthus is also involved, just to shorten up this space and give an overview out here. The crease is sometimes sutured along with this defect, just to strengthen up the eyelid defect that is reconstructed by the surgeon. Then over here you can see we have the other congenital eyelid defects ranging from the epicanthal folds. Usually we have two folds. We have the medial epicanthus, and on the other hand we have the lateral epicanthus. But the medial canthus is usually involved whenever we say we have this epicanthal condition in which the fold is accentuated in these individuals. Now, this phenomena can be quite physiological, usually found in the Mongolians or usually found in the Asian population. It's quite a normal phenomena that is seen by the individuals. The clinical presentation would usually include puffiness in the eyes. Again, we'd see that there is no fold, no crease fold that is quite accentuated in these individuals. Sometimes this crease fold is not available or it is not manifested in these individuals, and it can be again related to both of these. These two clinical symptoms are again correlated. The puffiness and the absence of the crease fold, they're again correlated in these individuals. Then we have the epicanthus. As you can see, this medial canthus is covering this medial margin of the eyelid. So that is the condition which is called as the epicanthal condition in these individuals. Then we have the vertically narrow palpebral fissures. So it's basically going to be a vertically narrow palpebral fissure, and the scleral show is going to be compromised whenever we are going to look at a patient. Now, what is a scleral show? Over here, you can see that whenever we look at a patient, we're going to see whether the sclera is available, or we can look at the sclera superiorly or not. As you can see, the palpebral fissure is quite shortened due to this epicanthus, and so the scleral show is again also compromised due to this narrowing of the palpebral fissure, which in comparison to the normal individuals is quite narrowed down. Then again, we have the deep set eyes. That is again due to the anatomical manifestation of the epicanthal folds in these individuals. The canthal tilt and the upslanting phenomena that are again going to be seen in these individuals. Then again, the classification. The classification is again going to depend upon the severity of this epicanthal fold that is available in these individuals. In some of the individuals, we have no epicanthal folds. This is a normal individual, as you can see. The medial canthus is in a normal anatomical position. The lateral canthus is in a normal anatomical position. Over here, you can see we have the epicanthus tarsalis. So it's the most slightest clinical presentation of the epicanthal folds. That is a type 2 kind of an epicanthus, which is also known as epicanthus tarsalis in these individuals. As you can see over here, the medial canthus is quite obliterated and the view is quite obliterated in these individuals. Then we have the epicanthus palpebralis. The epicanthal folds are severe enough that they're also affecting the complete eyelid, or that is why it is known as palpebralis. This palpebralis terminology is basically related to the eyelid. So if the complete eyelid is involved, it is going to be known as the epicanthal palpebralis over here. And then again, we have the epicanthus inversus. The epicanthal folds are severe enough. It is involving the complete eyelid, and even the palpebral fissure is narrowed down in these individuals. Over here, you can see the palpebral fissures are not quite narrowed down in two of these types, but over here you can see the scleral show as well as the vertical palpebral fissure length is also, or the folds are also affected in these individuals. So it's basically the classification that is depending upon the severity of the epicanthal folds involvement. So it's going to be a quite procedural kind of an classification involving the tarsalis muscle, involving the complete eyelid, and involving the inversal criteria, that is basically the epicanthal folds are involving or they are affecting the palpebral fissure as well, or the length of the palpebral fissure. Just giving you a detailed way where you can correlate the clinical signs and symptoms along with the classifications. Over here, you can see that we have an accentuated original crease without the epicanthus. So if you have a look at this epicanthal fold, it's usually more manifested in the Asian population. Or in the Mongolian population, in these populations, we see that we have an accentuated original crease out there, and the epicanthus is quite in a normal state. There is no epicanthal fold that is situated over here that can be clinically manifested in these individuals. And then in the second kind, we have a minimal epicanthus without crease. So it's not the involvement of the complete eyelid over here, but there is no crease out there. So the puffiness is examined in these individuals, or it's demonstrated in these individuals. Again, the puffiness is correlated to the absence of the crease, and there is a slight epicanthal fold that can be seen or that can be demonstrated at the medial ends. Over here, you can see that the epicanthus is accentuated, and even the original crease has again been demonstrated over here. Over here in the second part, or in the second type, you can see the crease is absent, or it has vanished due to the puffiness. But in the third kind, you can see that the crease has regained its place or its position, and again we have an epicanthal fold that is originating at the medial end. Then we have the epicanthus with a lower infold crease that can be seen over here. We can see that there is an epicanthal fold that is worsening in its severity, but the crease is still demonstrated in these individuals. And then we have the epicanthus without the crease. So we have the puffiness, we have the complete epicanthal fold that is involving the complete eyelid. We have the epicanthus with the epiblepharon. Now, what is the blepharon? Blepharon is a condition, or it's blepharophimosis. It's also termed as blepharophimosis. So if we have the epicanthus along with the epiblepharon, or the levator palpebrae fissure is also affected in these individuals, we're going to term it as a condition which is coupled up with the epiblepharon in these individuals. So this is a complete classification. Now over here you can see that we're just focusing on the epicanthal folds, or either we are focusing on the crease formation, whether it is formed in the individuals or not. And then finally, if it is a worsened condition, the levator palpebrae fissure is also going to be affected, and such a condition is termed as blepharophimosis in these individuals. The treatment would also be related to treat or to surgically manifest this epicanthal fold, that is the medial epicanthal fold that is accentuated in these individuals. So we'll have the triangular slips that would be raised, the triangular flaps that would be raised in these individuals. As you can see over here, these are the triangular flaps that are raised in these individuals, and then these basically the medial canthus is stretched out. And then finally, we're going to perform that reconstructive surgery in these individuals, having the Z-plasties, having the Z sutures. Again, the approximation is going to be in a twofold manner, approximating the muscles and then approximating the skin and the fascia. So the reconstructive outcome is quite good in these individuals. The prognosis is quite good in these individuals. And again, the prognosis and the outcomes are quite related to the initial condition or the severity of the symptoms in the individual. Moving on to the congenital entropion. Entropion can be defined as the inward eversion of usually the lower eyelid. So it's not the upper eyelid that is usually involved in the congenital conditions. It's usually the lower eyelid that is involved in these infants. Having a look at the anatomical structures, we have the upper eyelid and then we have the lower eyelid. This is the levator muscle that is situated over here. And then we have the glands that are somewhat situated over here. The lashes, as you can see, if there is a condition which is known as entropion, as you can see, there is an inward eversion of the lower eyelid shown in this figure. You can see that there can be a foreign body sensation due to this lash phenomena, and that is again going to result in the irritation and the corneal ulceration in these individuals, or these are going to be the presenting complaints by the individuals. We have a normal eye, and on the other hand, we have ectropion that is again going to be compared with the entropion. Ectropion on one hand is a condition in which we have a eyelid eversion, or the eyelid is everted outwards. Then we have another condition of entropion in which we have an inversion of the eyelid. So both of them will have their own clinical signs and symptoms. Usually when we are just dealing with a condition which is known as entropion, the condition is going to be manifested as a foreign body sensation by the individual, severe irritation, or the foreign body sensations are the presenting complaints that are given out by the patients who are suffering from this condition of entropion. The clinical picture is somewhat like this. It's basically the foreign body sensations are obviously going to be due to the eyelash phenomena that comes in close contact with the sclera and the cornea and the conjunctiva, and that is going to be affecting the visual acuity as well. There's going to be the visual field defects that are observed by the individuals due to this phenomena. So the visual acuity is going to be affected. There's going to be severe irritation and severe ulcerations that are going to be noted down by the patient, who is going to basically present out, and you're going to diagnose this patient as to be suffering from a congenital entropion condition. The reconstructive surgeries that are going to focus on the fact that the eyelid inversion is the problem or the defect that is faced by the individual. So the reconstructive surgery would be focused to treat that defect in these individuals. Over here you can see that the slit examinations are carried out, and then we're going to just point out towards any specific abnormality if it is present out there, and treat that abnormality in return, and perform any surgical sutures that can be just performed to cut and release the lateral canthal tendons in these individuals, and shorten the inferior tarsal plates. This can be the other phenomena that are treated out there whenever we are treating the epicanthal folds or the entropion conditions in these individuals. On the other hand, we just mentioned the blepharophimosis. So it can be a bilateral blepharophimosis syndrome that can be manifested in the individual. So we have a lot of conditions that are sometimes correlated to the blepharophimosis. It is basically the narrowing of the levator palpebrae fissure that is noted down in such individuals. As you can see, it can be related to the epicanthal folds. Again, it can be a compound condition that is also having the epicanthal folds, and on the other hand we have blepharophimosis that is noted down in these individuals. The surgical treatment that is related to this condition, which is known as blepharophimosis, is basically you're going to perform this crisscross surgery. So this cross is again very important, just to shorten out or just to elevate or the muscles out here at the medial canthus, and perform these triangular, or to narrow down these triangular folds. So basically we have these 4 triangular folds whenever we are performing this surgical procedure for treating the bilateral blepharophimosis. So we have these F1 and F2, F3 and F4. These are the 4 triangular folds that are raised off, or the triangular flaps that are raised off at this level. And then they are surgically approximated just to have a better reconstructive view after the surgeries. You can see that the scleral show is quite improved after the surgery over here. As you can compare both of these eyes, the scleral show is quite improved in the surgically treated eye over here. So this is a patient in which this Z-plasty, or in which we perform this surgeries on the medial epicanthus just to treat the epicanthus as well as the bilateral blepharophimosis in these individuals. On the other hand, we have another condition which is again quite important, and that is termed as the congenital ptosis. Now, what is ptosis? It's basically the drooping of the eyelids, which is termed as ptosis in these individuals. Ptosis can be an acquired condition. On the other hand, it can be a congenital condition. Usually we have the mechanical kind of ptosis that is related to the congenital ptosis, in which we have the neurofibromas that are the congenital neurofibromas or some other abnormalities that are drooping the upper eyelid mostly. So this is the most common condition that is associated. This is the mechanical kind of ptosis that is usually associated with the congenital kind of ptosis. Again, we have the other ranges of the ptosis. It can be the traumatic ptosis, the neurogenic or the myogenic ptosis, or the infectious states in which we have Horner syndrome, we have third nerve palsies that are usually associated with the ptosis. So this is basically the causative classification of the ptosis. Sometimes it can be related to the congenital kinds, and some of them are basically the acquired conditions such as the myasthenia gravis in these individuals. So this is the levator muscle that is usually involved for the retraction of the upper eyelid. As you can see, any contraction of this muscle is going to raise the upper eyelid. So if there is any abnormality that is relating to this levator muscle, that is going to result into the ptosis in the individual. The levator muscle over here, you can see if it constricts, it lifts the upper eyelid. So this is the correlation between the levator muscle and the ptosis. Any abnormality in this muscle would directly manifest as a condition of ptosis in the individual or in the infant. Then we have the right-sided congenital ptosis clinical presentation. As you can see that this is the right-sided congenital ptosis. This is the quite common clinical presentation in the infants or in the toddlers. You can see that if we compare it with the normal eye, the epicanthal folds are also quite prominent over here, and then the levator palpebral fissure and the drooping of the eyelid is noted down in these individuals. So these are the clinical signs and symptoms that are noted down in these individuals, and on the basis of these clinical signs and symptoms, we are going to diagnose this patient to be suffering from the unilateral or bilateral ptosis. Then over here you can see it's one of the conditions in which we have a bilateral congenital ptosis. Both of the eyelids are affected. So we say that this condition is of the bilateral congenital ptosis in these individuals. Dealing with the causative factors, again, the treatment modality would be related to the type of the causative factors that we are dealing with or that we are relating to in this particular individual. If it is some of the myogenic kind of a ptosis, we are going to treat the muscular factors first of all. If it's the nerve that is involved, then that is the underlying cause and that has to be treated in these individuals. If it's myasthenia gravis, steroids or is the systemic steroids are sometimes manifested in these individuals. But if we have to perform these surgeries in these individuals, then they are going to be focused upon the levator muscle primarily over here. Because as we related the levator muscle to be responsible for the retraction of the upper eyelid, so it's basically directly related to the ptosis as well. If there is any drooping of the upper eyelid noted down in the individual, usually it's the levator muscle that is affected or that has the pathology or the abnormality manifesting in such individuals. The levator muscle has to be treated, the skin incisions are given accordingly, and then they are plastied or they are approximated in these individuals just to get a better outer view or just to better a complete view in these individuals. So this is basically the, depending upon the causative factors or depending upon the causative baseline that gave way to the formation of a particular congenital condition, whether these are the muscles that are involved or the nerves that are involved, we'd be treating the condition accordingly in these individuals. So over here, we just overviewed the congenital conditions that are related to the eyelid defects. Either it can be the colobomas, that is the ring defects, or it can be some of the infectious conditions. It can be the conditions that are directly related to the eyelid. For example, entropion, blepharophimosis, or either it can be a condition which is characterized by the drooping of the eyelid and termed as ptosis. So we have a range of lectures that are is available on our website of sqadia.com related to ophthalmology, and do watch the other topics that are related to ophthalmology. Thanks for watching, and get a complete access to this website to watch the detailed lectures.